The facial symmetry was intact, a visible ulceroproliferative growth over the left buccal mucosa extending to the upper and lower lips inside up to the left lower third molar tooth, but the retromolar trigone was normal. Now this is what we have seen in the examination. I earlier said that involvement of retromolar trigone will lead to restriction in mouth opening. Here it is seen normal. That's why the patient is not having any restriction in mouth opening. 6 by 3 centimeters irregular margin, rolled out edges and slough necrotic material in fruit. Again, types of ulcer edges. Irregular margin, rolled out edges, more pointing out towards malignancy. If it would have been a regular margin, sloping edge, it would have been an healing ulcer. If it would have been a punched out edge, it would have been possibly a healing ulcer, or it would have been an aphthous ulcer in the mouth. If it had undermined edge, it would have been tuberculosis. That is what here our irregular marginal rollout edge is pointing towards malignancy. Mouth opening was adequate, poor oral hygiene with stains and halitosis, few leukoplaky patches and submucous fibrosis. No loosening of teeth, again confirmed. Tongue protrusion, opening of parotid ducts was normal. Now first thing to point out, what is adequate mouth opening? Remember, the distance between the upper and lower incisors has to be at least 3 centimeters. If it is less than 3 centimeters, we call it as restricted mouth opening. Here now in this image, I have purposely highlighted with different colors to understand. We can see the one which is highlighted with green color, that is at the both angle of the mouth, and upper one, that is the cupid bow area, that is a white, milky white smooth patch, which is your submucous fibrosis. Then the one with green patch on the left is also submucous fibrosis. The gray patch on the left is your leukoplakia, and the blue one is the ulcer which has raised up with irregular margins, rolled out edges with some yellowish necrotic material and slough. You can see the margin is irregular and it is coming up over the lower lip. Here now again a slight ugly diagram to see, I know, but this green colored is what is your submucous fibrosis again. Gray areas are leukoplakias and blue one is again the same ulcer, and this image we can see that ulcer is reaching inside the buccal cavity. This growth was non-tender, indurated base, a hard base which is going beyond the lesion. This is confirmatory now. If the induration is restricted to the lesion, the possibility of inflammation is more. But if it is going beyond the margins, the induration is going beyond the margins, it is again pointing towards malignancy. The ulcer was extending over the lower lip. There is no local rise of temperature, erythema, sinus scar or fistula. 7th, 9th, 10th, 11th and 12th cranial nerve examinations were normal. This is again to check the base of skull involvement. Trachea is central, 4 by 4 centimeter single hard fixed palpable lymph node at level 1B on left side. I'll talk about what is level 1B, but single, hard and fixed. Hard and fixed is again pointing toward malignant lymph nodes. Remember, if the lymph node becomes spheroid, if it becomes hard, if it becomes fixed, if it becomes non-tender, it is going to be a malignant change. If it is smooth or firm, if it is adhering, and if it is tender, it is an inflammatory lymph node. It is an inflamed lymph node. Carotid pulsation, scalp, cervical spine, ENT is normal. Here now let's see, this is the patient's neck area. The area 1A is the submentum, area 1B is submandibular, area 2 is the upper jugular, that is upper 1/3 along the sternocleidomastoid, 3 is middle 1/3 along the sternocleidomastoid, and 4 is lower 1/3 along the sternocleidomastoid, 5 is the posterior triangle, 6 is the central area just in front of the trachea. So this is all your levels of lymph nodes. So level 1A is submental, level 1B is submandibular, level 2 is upper jugular, level 3 is middle jugular, level 4 is lower jugular, level 5 is posterior triangle, and level 6 is central. So in this patient, what we can see, we have a lymphadenopathy of 1B. So a summary: 62-year-old chronic tobacco chewer who came to the OPD with painless ulcer. Left buccal mucosa was found to have 6 by 3 centimeters ulceroproliferative lesion. Growth over the left buccal mucosa extending up to the left lower third molar tooth and lower lip with leukoplakic patches, submucous fibrosis, 4 by 4 centimeters, single hard fixed cervical lymphadenopathy level 1B. A 62-year-old chronic tobacco chewer with ulceroproliferative growth, buccal mucosa, left buccal mucosa, cervical lymphadenopathy, and most likely to be a malignancy of oral cavity stage CT3N2AM0. Now let me talk a slight about staging. This is actually based on the AGCC guidelines 2018, that is the 8th edition of AGCC, which came recently in the last year. Based on that, the staging has been assessed in this patient. See, you cannot assess metastasis just clinically. You need a radiological investigation to rule out, and that's why it is M0. Okay, C means a clinical staging. If it has been treated chemotherapeutically or surgically earlier, we put it as X and the stage. If radiotherapy was done earlier somewhere else, it is staged Y. And if multiple such ulcers are there, we are going to stage separately for the separate ulcer. Okay, so here T3 into AM0, this is because of the staging. Now I'll just discuss a staging in short, but I'll be putting the post on what is the actual staging as per AGCC now. So just to say that T0 means there is no any lesion. T1 is the size of the lesion is less than 2 centimeters. T2 is 2 to 4 centimeters, or the depth of invasion is 5 to 10 mm. T3 means more than 4 centimeter size lesion, or the depth of invasion is more than 10 mm. T4A means there is a contiguous structure involvement and it is resectable. Like for example, what we talked about is involvement of angle of mandible, involvement of skin, involvement of alveolar processes. This will be a resectable contiguous involvement. T4B will be a non-contiguous structure involved, and it will be or it could be a contiguous structure involved, but it is not resectable. Like it is involving internal carotid artery, it is involving the base of skull. That will be a non-resectable one. You cannot resect if the mass is encroaching upon a blood vessel. So that will be T4B. N1 means if a ipsilateral single lymph node of less than 3 centimeters. N2A means if it's a ipsilateral single lymph node of 3 to 6 centimeters. N2B means if multiple ipsilateral of 3 to 6 centimeters. N2C means either bilateral or a contralateral lymph node of 3 to 6 centimeters. And N3 is ipsilateral or contralateral or bilateral or any lymph node which is more than 6 centimeters. It will be N3. So based on that, since our lymph node by 6 by 3 centimeter size, it comes under T3. Since it was a single ipsilateral lymph node of 4 centimeters, it came under N2A. And clinically, we cannot assess the metastasis. That's why it came to be M0. CCT will be done to stage the disease. Edge biopsy for histopath. Why edge biopsy? I have already explained it, that the edges of the ulcer show maximum proliferative activity, and that's why edge biopsy is preferred. Routine workup, pre-anesthetic workup before surgery. Now the treatment part is very important. We do a wide excision, lymphadenectomy, radiotherapy. Remember, for any mass lesion in the body, if it shows lymphatic metastasis at a greater extent, or lymphatic metastasis or lymph node involvement is a feature of that malignancy, three things have to be done. You have to widely excise the lesion, you have to do lymphadenectomy, and give a adjuvant radiotherapy with some indications. Why radiotherapy? I'll explain. Now wide excision we are doing with a margin of 1 to 2 centimeters because that will be the most possible margin of clearance. MRND type 3. Now what is MRND? MRND is modified radical neck dissection, which is a form of surgery which we do to clear out the lymph nodes, to remove the lymph nodes, to do a lymphadenectomy. See, earlier we used to do radical neck dissection where we used to remove all the 6 group of lymph nodes, 6 levels of lymph nodes, sorry. Then came the modification. What we used to do in a radical neck dissection is we used to remove all the 6 group of lymph nodes. We used to remove spinal accessory nerve, internal jugular vein, as well as sternocleidomastoid muscle of that side. But then we got that the functionally that is a very poor form of surgery. The functions are not retained. That's why we came up with a modified radical neck dissection. In type 1, we used to preserve only the spinal accessory nerve. In type 2, we used to preserve spinal accessory nerve as well as internal jugular vein. But now which we do presently in a surgery is MRND type 3, where we remove the levels up to level 6 lymph nodes and we preserve all the 3, that is spinal accessory, internal jugular vein and sternocleidomastoid. Then we do adjuvant radiotherapy. This is not done in all. This has to be done if it is a high grade lesion, it is encroaching upon a blood vessel, that is it was a not resectable tumor, and if it is a high grade not resectable, and if lymph nodes are positive, then we do a adjuvant radiotherapy. Again, it has to be a high dose radiotherapy. And then once the defect is formed, because we know we have excised the lesion, there will be some defect in the mouth, and especially there will be a defect at the lip. So we put a flap over there. Flap is a specific tissue removed and attached there or moved towards there. Now here in this case we have done a PMMC flap. There are many flaps to be discussed. Separately we will discuss about them, but PMMC flap is pectoralis major myocutaneous flap, where we are cutting some fibers of pectoralis major, making a flap based on thoracoacromial artery along with its covering skin, and then we will put that flap with the attached pedicle. We are not cutting with the pedicle, we are just moving that flap over the defect, and the remaining skin downwards from where we have mobilized the flap will be sutured primarily. This is the reconstruction which we have done in this case. There are many such flaps which can be used. So that was all about the oral cavity malignancies that I can give you in this stipulated time. Hope this could have helped you. Thank you for watching the video.